What if the medication you take every single day just to stop your pain is actually the exact biological mechanism that is making you hurt more?
It is a pretty terrifying thought.
It really is. When we think about medicine, we usually expect this kind of structural precision.
Right, like engineering.
Exactly, like engineering. You fall down, you break your arm, and you go to the hospital. The X-ray shows a clean, jagged white line right through the radius.
It is entirely binary. The bone is definitively broken or it is not broken. You can point right to the pathology on the screen.
Right, it is totally clean. You fix it with a cast, the bone knits back together, and, well, you move on with your life. It is a strictly mechanical process.
And it is comforting. We like things to be visible. Patients like to see the broken bone, and physicians really like to have a linear step-by-step solution to offer them.
But then you step into the world of chronic pain, and suddenly that X-ray machine is utterly useless. We are no longer dealing with a broken table leg here.
Not at all.
We are looking at a diagnostic and therapeutic landscape that is much more like predicting the weather. It is this highly complex, deeply entrenched, constantly shifting climate system within the human nervous system.
It is the absolute definition of clinical muddy waters. You cannot simply put a cast on a nervous system.
Welcome to the debate. Today, we are examining one of the most pressing and consequential issues in modern medicine.
And definitely one of the most controversial.
Oh, without a doubt. We are looking at the massive paradigm shift in how we understand and treat chronic pain. For decades, the medical establishment relied heavily on long-term opioid therapy. It was the standard, default approach for chronic musculoskeletal and neuropathic pain.
It was basically the gold standard for a very long time.
It was. But rapidly rising overdose rates, devastated communities, and a huge wave of new clinical research have called this entire foundational approach into question.
And that questioning has led to sweeping changes in prescribing guidelines, massive regulatory shifts, and a profound alteration in how chronic pain patients access care in this country today.
Right. So our discussion today will center on a fundamental crossroad. Do the evidence and the biology dictate that we should completely transition away from opioids?
Toward non-opioid, active self-management therapies.
Yes, because the drugs themselves are inherently flawed for a long-term use. Or has the backlash against opioids gone entirely too far, driven by systemic misconceptions that conflate physical dependence with the disease of addiction?
Ultimately abandoning vulnerable patients who suffer from intractable pain.
Exactly. So I will be taking the position that opioids simply fail the long-term efficacy test. They exact a severe physiological toll on the body that we are only just beginning to fully understand, and they must be replaced by a biopsychosocial model of active self-management.
And I will be representing the position that the current push against opioids is heavily influenced by a fundamental misunderstanding of the neurobiology of addiction. While multimodal care is absolutely the ideal standard, stripping away essential pharmacological tools ignores the brutal reality of severe chronic pain.
Which is a very real reality.
It is. And ignoring it has led to the widespread emergence of pseudo-addiction, where desperate patients are treated as addicts.
This discourse emerges directly from current peer-reviewed medical literature. Today we will be drawing extensively on the landmark SPACE trial comparing opioid and non-opioid efficacy,
as well as updated clinical guidelines for chronic non-cancer pain.
Right, and comprehensive psychiatric reviews examining the profound comorbidity of chronic pain and mental health disorders.
There is a lot of ground to cover.
There really is. So let us start by laying out our core perspectives. From where I sit, the medical establishment has historically relied on a deeply flawed passive intervention model.
Passive meaning the patient just receives the treatment without having to do much.
Right. We operated under this arrogant assumption that we could give a patient a chemical compound in a pill to cure a chronic, highly complex neurobiological ailment.
You think it was arrogant?
I do. For chronic pain, this approach is fundamentally broken. When we look at the data, the actual long-term randomized data, opioids simply do not provide superior long-term pain relief, or functional improvement for that matter, compared to non-opioids.
But we really have to look at how we are defining superior there, and for whom.
I agree. And we will absolutely get into the demographics of that data in a moment, but Worse than their lack of superior efficacy is their biological cost. I am focusing on the physical toll of long-term opioid use.
Beyond the overdose risk.
Yes, I want to be very clear about that. I am not just talking about the highly publicized risk of fatal overdose. I am talking about the insidious, chronic damage happening over years of use.
Like what, specifically?
I am talking about opioid-induced hyperalgesia. This is where the medication fundamentally alters the receptors in the brain to make the nervous system more sensitive to pain.
Which is a huge paradox.
It is a massive paradox, and I am talking about profound endocrine abnormalities, hypogonadism, immunosuppression, and massive losses in bone density.
Leading to devastating falls, especially in the elderly.
Exactly. Given these mechanisms, the only evidence-based, sustainable path forward is active self-management and multidisciplinary care. We must treat chronic pain as a complex, whole-person disease.
Meaning the patient has to do the work.
They have to actively retrain their brains, yes, rather than passively relying on a chemical crutch that ultimately erodes their physiology.
Well, I come at it from a very different way. The push toward entirely non-opioid treatments is a massive systemic overcorrection.
An overcorrection?
A huge one. It is fueled by societal fear, regulatory stigma, and honestly, a fundamental misunderstanding of basic neurobiology.
How so?
The critical and often entirely ignored distinction we have to make today is between predictable, physiological, physical dependence and the actual neurobiological disease of addiction.
Okay, the dependence versus addiction debate.
Right. Equating the two has been an absolute disaster for patient care. It has led directly to the undertreatment of severe pain and the rise of what we call pseudo-addiction.
Right. We will need to define that clearly later.
We will. But essentially, it is where a suffering patient who simply needs adequate pain relief is instead labeled a drug seeker. They get stigmatized and abruptly cut off from care.
But what about the self-management model?
I agree with you that multimodal, active self-management sounds absolutely perfect on a whiteboard in a multidisciplinary clinic. But it is a massive luxury.
A luxury? It is the recommended standard of care.
Sure, recommended, but it requires time, money, psychological resilience, and a physical baseline that not all patients possess. Discarding opioids based on highly specific, limited studies marginalizes millions.
Millions?
Yes, millions, who have relied on these medications safely and effectively for decades just to maintain their baseline quality of life.
Well, you brought up the idea of discarding opioids based on limited studies, which is actually the perfect transition here.
Let us get into the data.
Let us move from the philosophical overview right into the hard numbers. Because empirical data on real-world effectiveness is where this conversation really has to be grounded.
I agree. If the drugs do not work, the rest of the debate does not matter.
Exactly. If a treatment does not actually work better than safer alternatives, the rest of the debate about side effects and addiction is essentially moot. I want to deeply unpack the SPACE trial.
A very famous trial in this space, no pun intended.
Right, the Strategies for Prescribing Analgesics Comparative Effectiveness Trial. It was led by Dr. Aaron Krebs and published in JAMA.
And it is important to know what kind of trial this was.
Absolutely. This was not an observational study where we just look back at old medical records. This was a highly rigorous, pragmatic, 12-month randomized clinical trial.
Let us clarify what a pragmatic trial is for the listener, because it is a really important distinction from a traditional double-blind study.
Good point. A pragmatic trial is designed to test an intervention in the full spectrum of everyday clinical settings to maximize its real-world applicability.
Right, because clinical trials are often too perfectly controlled.
Exactly. In a tightly controlled double-blind study, patients might get exactly 5 milligrams of a drug at 8:00 a.m. every single day under intense supervision. But in the real world, people forget their pills.
They have bad days.
They have great days. They skip doses. Doctors adjust dosages based on complaints. The SPACE trial allowed physicians to adjust the medications, whether opioid or non-opioid, just like they would in a real clinic.
Following a step therapy algorithm, right?
Yes, following a step therapy algorithm to try to achieve the best pain control for that specific patient.
Right. It is meant to mimic real-world practice. And this was specifically within the VA system.
Right, Veterans Affairs. They took 240 VA patients with moderate to severe chronic back pain or hip or knee osteoarthritis pain.
These are people who were in significant daily pain.
Yes, despite already using over-the-counter analgesics, they randomized them into two groups. One received opioids, starting with things like morphine or oxycodone.
And the other group?
The other group received non-opioid medications. They started with things like acetaminophen or NSAIDs like ibuprofen, and then stepped up to nerve medications or topical analgesics if they needed more help.
And they followed them for a full year. We really cannot overstate how crucial that timeline is.
It is incredibly rare.
It is. So much of the pain literature historically relies on studies that only look at 6, 8, maybe 12 weeks of data.
Which is basically useless for a condition defined by lasting longer than 3 months.
Precisely. Acute pain mechanisms are completely different from chronic pain mechanisms. A 12-week study tells you how well a drug works before the body has fully neuroadapted to it.
Right, before tolerance really sets in.
Yes, a year gives us a real picture of chronic long-term use.
So over that year, they measured outcomes using the Brief Pain Inventory, or BPI. Let us break down what the BPI actually is, because it is not just the doctor asking, what is your pain on a scale of 1 to 10 today?
It is much more comprehensive than that.
It is. The BPI is a validated tool that measures both the severity of pain and how much that pain interferes with a person's life.
The interference is the key part.
Definitely. It asks about pain right now, but also average pain, worst pain over the last 24 hours, and least pain. And then it measures that interference you mentioned.
How it affects their actual daily living.
Right. How is this pain affecting your general activity, your mood, your walking ability, your sleep, your enjoyment of life? It is all scored from 0 to 10.
And 0 means no pain or no interference, and 10 means pain as bad as you can imagine or complete interference with function.
Correct. So we have 240 patients suffering from chronic pain, treated for a full year. And the results were completely stunning to a lot of people in the traditional medical community.
They definitely made waves.
Huge waves. The non-opioid group actually had better pain intensity scores over those 12 months. On the BPI severity scale, again, out of 10, the non-opioid group averaged a 3.5.
Okay.
The opioid group was at 4.0.
So a half-point difference on a 10-point scale.
Yes, a half point, but it is a statistically significant difference. And, more importantly, let us look at pain-related function. This is the interference score.
Right, how well they could actually live.
How well could these people actually move, sleep, and live their lives? There was no significant difference whatsoever. It was 3.4 for the opioid group and 3.3 for the non-opioid group.
Basically identical.
Identical. The opioids did not give these patients their lives back any better than Tylenol and ibuprofen did. But here's the kicker, and this is crucial. We have to look at the side effects.
The adverse events.
Yes. The adverse medication-related symptoms were double in the opioid group. They scored 1.8 versus 0.9 for the non-opioid group.
Well, sure, because opioids cause constipation, nausea, dizziness, fatigue.
Exactly. Using long-term opioids is like muting a fire alarm instead of putting out the fire, but with the added side effect that the mute button also somehow turns off the building's entire sprinkler system.
That is quite the analogy.
But it fits. You lose your hormonal balance, you lose your wakefulness, while the fire of the chronic pain still burns at a 4.0 out of 10.
I see what you were getting at.
So my question is, if the highest quality, 12-month randomized data shows that non-opioids literally outperform opioids for pain intensity, how can we scientifically justify initiating opioid therapy for these chronic conditions?
Okay, I have to stop you there, because we absolutely cannot use the SPACE trial as the ultimate, definitive gavel drop on all opioid prescribing.
Why not? It is the best data we have.
I agree it is a landmark study, but we have to look closely at generalizability. You are taking 240 patients. Out of the roughly 50 million people in the United States alone suffering from chronic pain, we are looking at 240 individuals.
It is a randomized sample.
But not just any individuals. These were specifically within the Veterans Affairs system.
The VA is a massive, highly representative healthcare system in the U.S.
It is massive, but it is not demographically representative of the general population, not by a long shot. The demographics of the VA are heavily skewed. These patients are predominantly male, often much older, and they carry highly specific physical and psychological comorbidities related to military service.
Sure, but pain biology is pain biology.
Is it? Even more importantly than the demographics, let us look at the actual pathology being studied. Look at the conditions they picked: back pain and osteoarthritis of the hip and knee.
Which happen to be the most common presentations of chronic pain in primary care.
They are very common, yes, but they are primarily nociceptive mechanical pain conditions.
Right, nociceptive pain.
Let us translate that for the listener. Nociceptive pain means pain arising from actual tissue damage. A deteriorating hip joint with osteoarthritis is a structural, highly inflammatory issue.
The cartilage wearing down?
Exactly. The cartilage is wearing away, the bones are literally rubbing against each other, and it creates a localized inflammatory response. Now, what were the non-opioids used in the trial?
NSAIDs, primarily.
Yes, non-steroidal anti-inflammatory drugs, NSAIDs, medications like ibuprofen or naproxen. These drugs are biologically targeted to reduce prostaglandins and treat that exact kind of joint inflammation.
So they worked as intended?
So of course they performed well. They are treating the direct underlying mechanism of the nociceptive pain. But does this apply to all intractable chronic pain? Absolutely not.
Are you arguing that opioids are better suited for neuropathic pain? Because, the literature generally shows opioids are actually quite poor at managing nerve pain.
I am arguing that millions of patients suffer from complex pain syndromes where NSAIDs do absolutely nothing. Or worse, they are contraindicated.
Contraindicated how?
Well, what about severe central neuropathic pain? What about complex regional pain syndrome, where the nervous system is in a state of autonomic dysregulation?
Those are much rarer conditions.
But they exist. And what about patients with severe gastrointestinal issues or kidney disease who literally cannot take NSAIDs because it will cause massive internal bleeding or acute renal failure?
Obviously, those patients need different modalities.
Millions of patients have historically achieved long-term pain control with opioids, where every single other modality completely failed them or caused severe organ damage.
I hear you on the specific nature of osteoarthritis. I really do, but I would frame it very differently.
How so?
The reason osteoarthritis and chronic back pain were chosen for the SPACE trial is precisely because they represent the vast majority of the chronic pain burden. For 20 years, the medical establishment told doctors that opioids were the absolute gold standard for these exact conditions.
We did prescribe them too broadly, I admit that.
We did, and if opioids fail to outperform Tylenol and NSAIDs in the most common presentations of chronic pain, it completely undermines the foundation of how they have been prescribed since the late 1990s.
Undermining that historical foundation is fine. I agree we prescribe them too broadly for mechanical issues. But my issue is that the conclusions drawn from the SPACE trial are being used to justify sweeping them off the table for everyone.
It is about changing the default.
But using one trial in a VA setting to create highly restrictive national guidelines cuts off patients who fall completely outside those specific parameters.
Guidelines are just guidelines. They are not laws.
But they function like laws in clinical practice. Doctors are terrified. Think of it this way. If a specific broad-spectrum antibiotic fails to treat a viral infection, we do not ban the antibiotic from the hospital.
No, of course not.
We recognize that we use the wrong tool for the job. We do not throw the baby out with the bathwater based on one highly specific demographic with mechanical joint pain. There is a deeply rooted danger in extrapolating the SPACE trial to mean, opioids do not work for chronic pain.
I am not saying they never work for anyone under any circumstances.
But that is how the data is being weaponized. They may not be the first-line choice for mechanical joint degeneration, but that absolutely does not render them obsolete for the broader spectrum of human suffering.
Let us follow that logic then. Even if we concede that the SPACE trial represents a specific subset of nociceptive pain, and even if we hypothesize that opioids work miraculously well for a small fraction of other patients with completely different pathologies,
Which they do.
Okay, but we cannot look at efficacy in a vacuum. Efficacy is only half of the medical equation. We have to look at safety.
Safety is paramount, obviously.
Right, and I want to pivot here because I am not just talking about the overdose risk, which is profound, heavily documented, and devastating. I want to dive into the hidden biological toll of long-term opioid use.
Beyond the respiratory depression.
Yes, way beyond that, because the physiological cost exacted on the human body over months and years of daily opioid ingestion is simply too high to justify their use as a baseline treatment.
You are referring to the systemic side effects.
Precisely. The medical community is finally waking up to the fact that these drugs do not just sit passively in the brain blocking pain. They are incredibly active systemically. Let us talk about opioid-induced hyperalgesia, or OIH.
This is a complex one.
It is, but it is one of the most fascinating and cruel paradoxes in modern medicine. When a patient takes opioids for a prolonged period, the drugs do not just mask the pain. They fundamentally alter the structure and function of the nervous system itself.
Just so we are clear for the listener, how does this differ from standard tolerance? Because people often confuse the two concepts.
It is a great question. Tolerance simply means the receptors get used to the drug, so you need a higher dose to get the exact same pain relief.
Right. The drug just stops working as well.
Exactly. The baseline pain has not changed. The drug is just less effective. But opioid-induced hyperalgesia is entirely different. With OIH, the brain senses that its pain receptors are constantly being blocked by the opioid.
It senses the blockade.
The central nervous system actually upregulates.
It fights back.
It fights back. It creates more pain pathways. It becomes massively hypersensitive.
It lowers the threshold for what constitutes a painful stimulus.
Exactly. The patient actually becomes more sensitive to pain. A gentle touch, like clothing just resting on the skin, can feel like a burning needle.
Allodynia.
Yes, allodynia. The baseline pain expands and radiates to areas of the body that were never injured in the first place. The very treatment prescribed to alleviate the disease ends up actively, biologically exacerbating it.
It is a vicious cycle.
It is terrible. And that is just the nervous system. The endocrine system takes a massive, often completely unmeasured hit.
Through the HPA axis.
Right. The hypothalamic pituitary adrenal axis. Let us trace this mechanism, because it is vital. Opioids bind to mu-opioid receptors in the hypothalamus.
Deep in the brain.
Right. When they bind there, they inhibit the release of gonadotropin-releasing hormone, or GnRH. Without GnRH, the pituitary gland stops releasing luteinizing hormone.
It cuts off the signal downstream.
Exactly. And without luteinizing hormone, the testes or the ovaries simply stop producing testosterone and estrogen. This is opioid-induced hypogonadism.
Which leads to severe sexual dysfunction, profound fatigue, and amenorrhea, the loss of the menstrual cycle in women.
Yes, and it gets even worse. What do estrogen and testosterone actually do?
They do a lot of things.
They do, but crucially, they are critical for bone remodeling. They balance the osteoblasts that build up the bone and the osteoclasts that break it down.
The constant cellular turnover.
Right. When opioids crash your hormone levels, that delicate balance is completely destroyed. The bones literally begin to hollow out over time. This is osteopenia and eventually osteoporosis.
Which makes the skeleton brittle.
Extremely brittle. On top of that, you have massive immunosuppression, making the patient incredibly vulnerable to infections. You have the disruption of sleep architecture.
The sleep issues are huge.
They are. Specifically, opioids suppress REM sleep and they cause central sleep apnea. That means the brain temporarily stops telling the lungs to breathe while you sleep.
And all of this culminates in a massive frailty risk.
Exactly. Frailty. I want you to picture an older patient who is prescribed opioids for a bad knee. 3 months later, because of the medication, they are suffering from severe sleep deprivation due to the sleep apnea.
So they are exhausted.
They have cognitive fog. They get dizzy standing up because of blood pressure drops. They fall. And because of the opioid-induced bone loss we just traced, they shatter their hip.
It is a catastrophic event.
It is. The relative risk for bone fractures in patients on long-term opioids is 1.38. That is a 38% higher risk of breaking a bone.
Wow.
They end up infinitely worse off,
bedridden, facing massive surgical interventions than if we had never treated the knee pain at all. That is an active iatrogenic harm, meaning an illness caused directly by our medical treatment.
Look, you are painting a terrifying picture, and the biological mechanisms you are describing are accurate. I will give you that. That is a compelling argument.
Thank you.
But you are painting the alternative as if it is a healthy baseline. You are presenting the side effects of opioids as if the choice is between taking a dangerous drug or existing in a neutral, peaceful state.
I am not saying chronic pain is peaceful.
But that is how it sounds. That is not the reality for these patients. Untreated chronic pain is a severely destructive physiological state in itself.
I am not suggesting pain is not harmful, but we are comparing the disease to the highly toxic effects of the cure.
But you have to measure them against each other realistically. Untreated chronic pain is not just an unpleasant sensation you have to grit your teeth through. It is a systemic biological stressor that absolutely wrecks the body and the mind.
How so, biologically?
When the body is in severe pain, it is in a constant state of sympathetic nervous system arousal, fight or flight. Cortisol levels are continuously elevated.
Chronic stress.
Yes. And that chronic stress destroys the immune system just as effectively as the opioids do. Untreated pain causes severe chronic sleep deprivation, which destroys cognitive function and emotional regulation. It causes massive physical deconditioning because the patient literally cannot move due to the agony.
And you believe opioids effectively mitigate that stress response long term?
I believe that for some patients, they are the only thing that allows them to get out of bed and break that cycle of deconditioning. Let us look at the mental health data.
Okay, let us look at it.
If we look at the comprehensive psychiatric umbrella reviews, and we are talking about massive data sets here spanning nearly 1 million people with mental disorders and 16 million healthy controls, the bidirectional relationship between chronic pain and mental health is absolutely staggering.
Bidirectional meaning the pain causes the mental health issue and the mental health issue exacerbates the pain.
Exactly. They feed on each other in a vicious, endless loop. In patients with major depressive disorder, the prevalence of chronic pain is over 60%. And look at the odds ratios. Depression increases the risk of developing chronic pain with an odds ratio of 1.26 to 1.88.
Let us clarify that odds ratio for the listener. An odds ratio of 1.88 essentially means an 88% higher likelihood, correct?
Yes. If you have major depression, you are 88% more likely to develop a chronic pain condition than someone without depression, and vice versa. Having widespread physical pain massively increases your risk of developing clinical depression.
It is deeply interconnected.
It is. Now look at PTSD. The prevalence of chronic pain in patients with post-traumatic stress disorder is between 88 and 96%.
That is an astonishing number.
Think about that for a second. If you have PTSD, there's a 90% chance, 9 out of 10 patients, that you are also living in chronic physical agony. You cannot separate the mind from the body here.
I agree with that premise.
These patients are living in a constant state of neurological hyperarousal and physical torment. By withholding opioids out of fear of hypogonadism or opioid-induced hyperalgesia, are we actively condemning patients to the devastating, measurable biological and psychological destruction of relentless, unmitigated pain?
But are the drugs actually helping the psychology?
They are providing relief. We worry about the elderly patient falling and breaking a hip, and we definitely should. But what about the 45-year-old patient whose untreated pain leads to such severe depression, isolation, and hopelessness that they become part of the 5 to 14% of chronic pain patients who attempt suicide?
Suicide risk is a very serious concern.
It is the ultimate concern. We are hyper-focusing on the iatrogenic harm of the drug while ignoring the fatal harm of the untreated disease.
I see the gravity of what you are saying, but let me give you a very different perspective on that exact demographic. You are framing opioids as the only barrier between that 45-year-old patient and total psychological collapse. My argument is that opioids are a false barrier.
A false barrier?
Yes. They are an illusion of a barrier.
How so? If a patient takes the medication and their pain goes from an 8 to a 4, and they can finally go to their kid's soccer game, That is not an illusion. That is real life.
It is an illusion over the timeline of years. The epidemiological data shows that patients on long-term opioid therapy actually experience worse overall body pain, worse physical function, and worse mood than patients with similar pain conditions who are not taking opioids.
Correlation does not equal causation there. Maybe the patients on opioids just have inherently worse pathology to begin with.
Researchers control for baseline pain severity. The drug isn't saving them from the psychological toll, it is actively compounding it. Because eventually the efficacy wanes, the hyperalgesia sets in, and now they still have the intractable pain, the severe depression, and a severe physical dependence on a Schedule II narcotic.
And that brings us to the absolute core of the issue and the primary reason we are currently failing these patients. You just used the phrase physical dependence.
I did.
The medical community, the media, and society at large have fundamentally conflated two very different biological phenomena: physical dependence and the disease of addiction.
Okay, let us get into this.
This crucial misunderstanding is driving the entire restriction cascade we are seeing today. We are terrifying doctors out of prescribing because they think every dependent patient is an addicted patient.
Let us define our terms then, because the literature is very clear on these definitions, even if the public is confused. What are the clinical distinctions exactly?
Let us look at the parameters set by the New England Journal of Medicine, the American Society of Addiction Medicine, and essentially every modern neurobiological textbook. We have three distinct concepts that constantly get thrown into the exact same bucket: tolerance, physical dependence, and addiction.
We touched on tolerance earlier.
Right. Tolerance simply means neural adaptation. The body gets used to the drug, the receptors downregulate, so you need a higher dose to achieve the same analgesic effect. That happens with caffeine, it happens with antidepressants. It is a completely normal physiological process.
Everyone agrees on that.
Then we have physical dependence. Physical dependence means the body has physiologically adapted to the continuous presence of the exogenous chemical, the drug. The body has found a new homeostasis.
Right, a new baseline.
If you abruptly stop taking the drug, the body is thrown out of balance and goes into withdrawal. With opioids, withdrawal looks like severe flu symptoms: chills, nausea, vomiting, severe muscle aches, diarrhea, and intense insomnia.
It is a brutal physical experience.
It is brutal, but it is a highly predictable, normal biological response. If you take opioids daily for a few weeks, you will be physically dependent. It is a guarantee. Your body will adapt.
Yes, that is basic pharmacology.
Addiction, on the other hand, is completely different. Addiction, or severe opioid use disorder, is a distinct, primary, chronic neurobiological disease. It is not just about the body needing the drug to avoid withdrawal. It is about the brain's reward circuitry being profoundly hijacked.
The mesolimbic pathway.
Exactly. It is characterized by impaired control over drug use, obsessive thinking about the drug, the profound erosion of inhibitory control in the prefrontal cortex, and compulsive use despite severe harm to the user's life.
So the dependent patient takes the drug to avoid withdrawal and function normally. The addicted patient will steal from their family, lose their job, and forge prescriptions to get the drug, regardless of the consequences.
Exactly. No one disputes the clinical definitions today. The problem is our history. Older medical texts, specifically the DSM-3 and DSM-4, the diagnostic manuals used by psychiatry for decades, literally equated physical dependence with addiction.
They conflated the terminology.
They codified a massive clinical error. They told an entire generation of doctors that if a patient goes into withdrawal, they are an addict. So now when a physician sees a patient who experiences withdrawal symptoms because a pharmacy was late filling a prescription, or who develops tolerance and asks for a slight dose increase, the physician panics.
They see red flags everywhere.
They think, oh no, my patient is addicted. I am causing an addiction. We expect physical dependence. It happens within days. We should not fear it as if it is addiction. Consider a diabetic.
Okay, here we go.
A diabetic is physically dependent on insulin. If they stop taking their insulin abruptly, they will suffer severe, life-threatening, withdrawal-like consequences. Their blood sugar will spike. They will go into ketoacidosis. but no rational doctor on earth would look at a diabetic and say they are addicted to insulin.
I understand the point you are trying to make, but that is a deeply flawed biological analogy.
How so? The body relies on an exogenous substance to maintain homeostasis. It is the same basic principle.
Because insulin does not trigger the brain's mesolimbic reward pathway. Insulin does not cause a massive cascade of dopamine in the nucleus accumbens. Insulin doesn't cause a patient to doctor shop, buy heroin on the street when their prescription runs out, or abandon their families. Opioids do.
Addiction does that, not physical dependence.
But the drug causes the addiction. And because opioids tap directly into that ancient mammalian reward circuitry, separating dependence from addiction is infinitely more difficult than you are making it sound.
But because we confuse the two, we have created the terrible tragedy of pseudo-addiction. I want to explain what this looks like in the real world, because it is heartbreaking.
Okay. Let us define pseudo-addiction.
Pseudo-addiction is a documented clinical phenomenon where a patient is in severe, unremitting pain because their prescribed dose is simply too low. Their pain is undertreated.
Wait, pseudo-addiction? How is that clinically distinct from actual addiction? What does that actually look like in a busy primary care waiting room?
Here is exactly what it looks like. You have a patient with severe neuropathy. Their prescribed dose is too low. The medication wears off 4 hours before their next dose is due. So what do?
They complain.
They sit in the waiting room watching the clock. They call the doctor's office repeatedly. They ask for their medication early. They might even go to the ER complaining of pain. To an uneducated, fearful observer or a doctor under massive pressure from the DEA, this looks exactly like drug-seeking addictive behavior, the obsessive focus on the medication.
Because it directly mirrors the behavioral symptoms of opioid use disorder.
It mimics it on the surface, but the underlying drive is completely different. They aren't trying to get high. They are desperately trying to escape torture. If you take that patient and you give them an adequate dose of analgesia, if you actually treat their pain effectively, the addictive behaviors completely vanish.
They just stop?
They stop watching the clock, they go back to work, their function improves. But instead of recognizing pseudo-addiction, our current system labels them addicts. We cut off their medication, flag their chart as a drug seeker, and send them into an agonizing spiral of withdrawal and completely untreated pain.
I hear the empathy in your argument, I really do, but I have to push back hard on this. You're assuming we can easily, safely, and accurately separate the dependent, pseudo-addicted patient from the truly addicted patient in a 15-minute primary care visit.
We can look at the whole clinical picture.
We absolutely cannot do it reliably. You say addiction is not a predictable result of opioid prescribing. You are right, it is highly unpredictable, which is exactly what makes prescribing these drugs incredibly dangerous on a population level.
We know not everyone gets addicted. The vast majority of chronic pain patients do not.
But we cannot predict who will. Genetic vulnerability accounts for roughly 35 to 40% of the risk associated with developing an addiction.
It is multifactorial.
It is a highly heritable disease, much like asthma or hypertension. Someone can have a genetic predisposition to opioid use disorder and never know it until they are prescribed Vicodin for a root canal or chronic back pain. We currently have no proven, definitive genetic biomarker screening to identify who carries that vulnerability before we hand them a prescription.
We do not have genetic tests, but we have clinical risk stratification tools. We know that prior substance abuse, severe psychological trauma, adverse childhood events, and young age elevate the risk. We can and we do screen for those.
And even with those screening tools implemented across the board, the literature is grim. Studies show that 25 to 30% of chronic pain patients on long-term opioids demonstrate misused behaviors.
But define misuse. That is a tricky word.
Taking higher doses than prescribed, using the drug for reasons other than pain, like to sleep or to manage anxiety, or obtaining drugs from other sources. 1 in 4 patients. That is not an acceptable risk profile for a primary line of treatment. Furthermore, we need to talk about the terrifying biological reality of what happens when the lines between dependence and addiction blur, specifically regarding detoxification.
You are talking about the overdose risk following a taper.
Yes. Let us look at the mechanics of detox and relapse.
When an addicted person goes through detox, or when a dependent patient is forced to taper because their clinic suddenly changes its guidelines, they lose their physical tolerance over a period of weeks.
Their receptors readjust.
The receptors upregulate again. Their body is no longer used to the massive doses of opioids, but the underlying neurological brain changes of addiction, the intense cravings, the deeply eroded inhibitory control in the frontal lobe, those neuroadaptations persist for months, sometimes years.
The psychological drive remains long after the physical protection is gone.
Exactly. If that patient relapses in a moment of weakness or a moment of severe pain and they take the exact same dose they were safely taking just a few months prior, it is now lethal.
Because the tolerance is gone?
Your protective tolerance is gone, and that dose suppresses their brainstem until they literally stop breathing. This is why overdose risk skyrockets immediately after detoxification or forced tapering. By initiating long-term prescribing, we are playing a game of biological roulette. We are introducing a chemical that fundamentally alters brain architecture in unpredictable ways. The volatility is baked into the pharmacology of the drug itself.
But you are using the statistics of misuse, that 25 to 30% number, which many experts argue is artificially inflated precisely because it includes the very patients exhibiting pseudo-addiction that I just described.
How is it inflated?
If a patient takes one extra pill on a Tuesday because a winter storm made the barometric pressure drop and their osteoarthritis became absolutely unbearable, that is recorded in these studies as aberrant drug-taking behavior or misuse. It is not addiction. We are criminalizing the human attempt to find relief from suffering.
Look, whether the root cause is pseudo-addiction, poor coping skills, or true neurobiological addiction, the outcome is exactly the same: a loss of control over the medication regimen, and when you lose control over a drug that causes fatal respiratory depression, the risk of death escalates exponentially.
You are catastrophizing the risk.
This inherent volatility, the fact that a slight miscalculation by the patient can result in death, is exactly why we need a complete paradigm shift. If pharmacological tools are fraught with long-term efficacy failure, physical degradation like hyperalgesia and bone loss, and the unpredictable, genetically modulated risk of addiction, the only logical step is to redefine how we understand and treat pain entirely. We have to move away from the passive fix-me model and fully embrace the biopsychosocial model.
So we arrive at active self-management and multimodal rehabilitation.
Yes. The goal of chronic pain treatment must undergo a fundamental philosophical and clinical shift. We have to look patients in the eye and stop telling them we are going to cure or eliminate their chronic pain.
Which is a very hard conversation to have.
Leading fatal prescriptions. The goal must shift to managing the pain, restoring physical function, and improving quality of life despite the presence of some pain. This requires active self-management.
Define active versus passive coping for the listeners, because it is central to this new paradigm. How does this actually look in a patient's daily life?
Passive coping is what our modern healthcare system has unfortunately trained patients to do. It involves resting constantly, avoiding any activity that might cause even a twinge of pain, venting emotions without processing them, and passively taking a pill or receiving an injection, basically waiting for the doctor or the drug to do all the work.
It treats them like a car in a shop.
It treats the patient as a broken machine waiting for a mechanic. Active coping requires the patient to be the primary agent of their own healing.
Which requires immense effort.
It does. It means daily, graded exercise to improve aerobic capacity and flexibility. And this isn't just about getting stronger muscles. Aerobic exercise actually induces exercise-induced hypoalgesia.
The runner's high mechanism?
Right. A biological release of endogenous opioids and cannabinoids that decreases the sensitivity of the nervous system to pain. It involves cognitive behavioral therapy, or CBT.
And how does talking to a therapist fix a physical pain signal originating in the lower back? We have to explain that mechanism, or it just sounds like we're telling patients the pain is all in their head.
It is absolutely not all in their head in an imaginary sense, but it is in their brain, because the brain processes all pain. CBT targets pain catastrophizing and fear avoidance beliefs. Let us look at the descending pain modulatory system.
The pathways coming down from the brain.
Exactly. The prefrontal cortex, the logical thinking part of the brain, has neural pathways that travel down the spinal cord. When a patient is terrified of their pain, when they catastrophize and think, this will never get better, my spine is crumbling, the brain actually amplifies the pain signals coming up from the body.
It turns up the volume.
But through CBT, when a patient learns to reframe those thoughts and reduce the fear, the prefrontal cortex sends inhibitory signals down the spinal cord. It literally gates the pain signals, reducing the volume of pain the brain perceives. Active coping means learning to adaptively ignore certain safe pain sensations rather than letting them dictate behavior.
It means treating the whole person, integrating the mind and the body.
Exactly. It requires a multidisciplinary team. Physicians, pain psychologists, physical therapists, occupational therapists, and pharmacists all working together. The literature is unequivocal here. Chronic pain is an issue of the nervous system becoming overly sensitive, a state of central sensitization.
Neuroplasticity gone wrong.
Right. The aim is to retrain the brain through positive neuroplasticity. By changing behavior, we physically rewire the neural networks processing the pain. Now, a skeptical patient might say, well, CBT only reduces my pain by 10%. That is not enough.
And they would be right.
Looking at it in isolation, that might be true. But if CBT gives 10% relief by reducing catastrophizing, and physical therapy gives 20% relief by improving joint stability, and optimized sleep hygiene gives another 10% by allowing the brain to heal, a multimodal approach stacks these benefits.
Synergy.
Synergy. Suddenly, you have a 40 to 50% overall improvement in function without the massive risks of long-term opioids. Isn't it fundamentally more ethical to empower a patient to take control of their nervous system through self-management, rather than tethering them to a passive, dangerous medical system for the rest of their lives?
I agree that active self-management and multidisciplinary, multimodal care is excellent. It is beautiful. It is the gold standard in theory, but it is highly, almost laughably problematic in practice for the vast majority of patients.
Why laughably?
You are advocating for a utopian system that barely exists outside of elite, well-funded academic medical centers in major metropolitan areas.
The clinical guidelines are clear that this is the standard of care we must strive for.
But we have to treat patients in the messy reality of the healthcare system we currently have, not the utopian system we wish we had. Let us talk about the immense privilege, the socioeconomic factors, and the systemic barriers required for this multidisciplinary care.
It is a challenge, I admit.
You just listed a massive team, a pain psychologist, a physician, a specialized physical therapist, an occupational therapist. Do you know how hard it is to get a referral to a specialized pain psychologist? They are incredibly rare. In many states, there might only be a handful. How is a rural patient living 2 hours from a major city supposed to access this team?
Telehealth is expanding access to CBT. That is a huge development.
Telehealth helps, sure, but it doesn't solve the physical therapy aspect. Furthermore, these comprehensive functional restoration programs take weeks, months, or years of dedicated work. In highly intensive programs, it is 6 to 8 hours a day for several weeks.
Which is what it takes to rewire the brain.
But how does a single mother working 2 minimum wage jobs afford the time off work, the transportation, or the massive copays for comprehensive multimodal rehab?
The lack of insurance reimbursement for non-pharmacological treatments is a major recognized barrier. The guidelines explicitly acknowledge that payers and insurance companies need to step up and cover these modalities.
But until they do, you cannot take away the pills. It's not just the money, it's the physical and psychological baseline required to actually do the work of self-management.
What do you mean by baseline?
You are asking a patient who is in screaming, relentless agony to somehow find the mental and physical fortitude to do physical therapy, practice mindfulness, and engage in cognitive restructuring. We know that patients with chronic pain desperately want to retain their dignity.
Of course they do.
Telling a patient whose entire life has been derailed by a shattered pelvis or severe diabetic neuropathy to reframe their thoughts or practice sleep hygiene when they are jolted awake by nerve pain every 20 minutes can feel incredibly dismissive. It feels insulting and patronizing if it is not paired with effective, immediate pharmacological pain relief.
I am not saying it is easy.
I am saying it is the only path that actually results in long-term healing.
But are we using the beautiful ideal of self-management as a convenient excuse to abandon patients? Because that is what is happening right now in clinics across the country. We are abandoning patients who lack the financial resources, the mental health baseline, or the physical capability to engage in intensive multidisciplinary rehab. Don't they deserve a baseline of chemical pain relief so they can even begin to self-manage?
A chemical baseline?
Yes. You cannot do cognitive behavioral therapy when you are blinded by pain. You cannot do physical therapy if you cannot put weight on your leg.
That is a powerful point about the socioeconomic realities of our healthcare system. But again, returning to the SPACE trial and the extensive systematic reviews, we do not have the evidence that opioids actually provide that necessary baseline over the long term.
They do for many.
They provide it for a few weeks, maybe a few months. But eventually, the neuroadaptation occurs. The tolerance builds, the hyperalgesia sets in, the patient's physical function declines, and they are left with the exact same level of baseline pain they started with, plus a physiological dependence on a dangerous narcotic.
That is a worst-case scenario.
It is a common scenario. The chemical baseline you are advocating for as a bridge to therapy is a biological mirage. It evaporates. We have to endure the incredibly difficult transition to self-management because the alternative, relying on opioids as the foundation of care, has resulted in a public health catastrophe.
The catastrophe of the opioid epidemic was absolutely real, but it was driven by irresponsible prescribing for minor acute pain, predatory pharmaceutical marketing, pill mills, and the massive influx of illicit street fentanyl.
All true.
It was not driven by the careful, long-term management of intractable chronic pain by responsible physicians. By conflating illicit addiction with chronic pain management, we are punishing the most vulnerable, suffering patients in our healthcare system for a crisis they did not create.
Well, we are nearing the end of our time, so let us summarize where we stand, because this is a profoundly complex issue that affects millions of lives. My position is rooted firmly in the empirical evidence, notably the 12-month data from the SPACE trial, which clearly demonstrates that opioids are not the long-term functional solution they were promised to be.
For osteoarthritis and back pain.
When we factor in the devastating biological toll, the endocrine failure, the opioid-induced hyperalgesia, the severe risk of bone fractures, and the entirely unpredictable genetically loaded risk of addiction, the clinical math simply does not support chronic opioid therapy. The future of pain medicine must be rooted in active, multidisciplinary self-management.
Which requires a perfect system.
We must treat the whole person, utilizing the science of neuroplasticity to retrain the nervous system through physical and psychological therapies, rather than relying on a passive, failing chemical intervention that ultimately causes more harm than good.
And my summary is that while multimodal care represents a vital, incredibly necessary evolution in chronic pain treatment, we are currently engaging in a dangerous reactionary overcorrection by universally demonizing opioids.
We aren't demonizing them, we are evaluating them.
By allowing historical diagnostic errors to confuse physiological dependence with the destructive disease of addiction, the medical community risks entirely abandoning patients with severe, intractable pain. We are pushing them into the agonizing state of pseudo-addiction, demanding these self-managed conditions that are fundamentally unmanageable without a pharmacological baseline, especially given the systemic barriers to care. We must retain the clinical nuance to use all the tools available to us, including opioids, for the patients who genuinely, desperately need them.
Despite our strong disagreements on the role and safety of pharmacology, I think there are significant areas of convergence here that are important to highlight. We both readily acknowledge that chronic pain is one of the most complex, dynamic, and challenging diseases in modern medicine.
Without a doubt.
It is not just a symptom, it is a disease of the nervous system itself.
Absolutely. We both completely agree that a purely passive, single-pill approach, whether that pill is an opioid, an NSAID, or anything else, is entirely inadequate for a biopsychosocial disease of this magnitude.
And we also align on the critical importance of mental health in this equation. Treating comorbid conditions like depression, anxiety, and PTSD is not peripheral to pain management. It is absolutely essential, biologically and psychologically, to any successful strategy.
And finally, we are in complete agreement that our current healthcare infrastructure utterly fails to properly fund, support,
and provide equitable access to the ideal multidisciplinary teams required to tackle this crisis ethically and effectively. Until that changes, patients will continue to suffer in the gap between ideal care and reality.
There is vastly more to explore in the rapidly evolving science of neuroplasticity, endocrinology, and pain management. The medical literature continues to grow, our understanding of the brain deepens every year, and the clinical guidelines will undoubtedly continue to shift as new evidence emerges. We leave it to you, the listener, to weigh the volatile, complex risks of pharmacological intervention against the demanding and often systemically inaccessible reality of self-management. When you look at chronic pain, remember, we are not fixing a broken table leg. We are trying to understand, predict, and change the weather inside the human nervous system. Thank you for joining the debate.